Good evening, everyone. So, Dr. Senthil has put a nice background to what I'm going to speak. I'm a neuroradiologist by profession, and Dr. Senthil is an MR physicist by profession. And then, when you listen to us, you will know that we merge, our talks merge, and that is what the beauty of this field is. So, coming to today's presentation, I have kept it simple to talk to the students of this university, because the entire work which I am going to present has been done by my students who are doing PhD in neuroimaging and interventional radiology. They are the ones who have taught me about AI, and I always tell that I have the RI, which is a real intelligence, and they taught me artificial intelligence, but the field is more than interesting. So to get you in line, I thought I will do my talk in the same language that you speak, divide them into methods where I have used supervised learning, methods where I have used unsupervised learning, and deep learning in various diseases. So from this talk, you will come to know what the challenges that we face when we interpret diseases, and what we wish that where we can see a patient beyond the boundaries of clinical radiology. So essentially what we do is that when we when we get an image, we have to process the image, because the raw image cannot be used, because we don't require so much of soft tissue, skull, face. We don't require that for getting information from the brain. So we remove out noise. That is what pre-processing. We use pipelines to extract features and then put it in the machine learning pipelines, or without extracting features, use it directly into deep learning and get the output. And that is what typically all pipelines do. So now the first, our first adventure into this field was probably somewhere in 2018, where we wanted to see networks in epilepsy. So now what is epilepsy, especially temporal lobe epilepsy? It's a network disorder with refractory epilepsy. That means patients get repeated seizures, and patients require lifelong medications. That means they cannot be off medicine, and even with complete medicines, they still get seizures. Some of them, when they have an MRI abnormality like hippocampus which is shrunken, they can get benefited from surgery. But what we are doing while removing that temporal lobe is not actually removing the disease. We are actually removing the hub in the network. So it's always our wish to see networks in temporal lobe, in epilepsy, so that if we can target the smallest hub and then cure the patient, then we don't have to do an extensive surgery to remove the entire temporal lobe, because removing a part of the brain is definitely going to cause problems in memory, problems in attention, problems in behavior. And we cannot have patients with like that. So we did this, and we used a support vector machine pipeline in 42 patients of temporal lobe epilepsy and 90 controls. And what we used was resting state functional MRI as a method. So now Dr. Senthil was telling you about task-based functional MRI, where we can look at bold response. Even when you are at rest, there is bold response which is happening in the brain. There is a differential pattern of blood supply to the brain, and this can be mapped, and this can be mapped mathematically using platforms like independent component analysis, where we get different networks mapped out separate. And then we can look at what has happened to these networks. This is one of the prototype networks that we see, called the default mode network, where you have anterior cingulate, medial frontal, posterior cingulate, parieto-temporal, lateral temporal areas being connected and working as one unit. So they work as single unit, and that is called a default mode network. Like that, we have like 10 to 20 networks in the brain, which we can identify using this technique, and which work together and sometimes independently also to do the tasks, especially cognitive tasks. So this was our pipeline, where after processing pre-processing the images, we did the group ICs, took the time courses, correlation matrix, put in the black box, which is actually the elastic net, and then did an SVM and got the output, we took the feature ranking and then did a correlation with the clinical findings, because we were not sure whether, because we wanted to know what is the clinical meaning of what we are finding. So what we found, really interested us. Why? Because from day one, we knew that we are dealing with networks which is abnormal, especially in the temporal lobe, in the thalamus, the occipital lobe, in the frontal lobe. We knew that these are the networks which are abnormal in patients with epilepsy, because several research have found. What we also found in addition was that there are other networks in the parietal lobe, in the salient network, and in the cerebellum, which are also involved in making the disease refractory. And then we knew that, okay, fine, we have to believe this, because the strength of these networks were positively correlating with the duration of epilepsy and negatively correlating with the age of seizure onset. That means, younger the child gets a disease, the networks are stronger. So this data actually made me personally believe in the, fine, there is some science, there is something which is going on inside this black box. So let us explore this further. So then we did the same thing in EEG microstates. Microstates are also large-scale networks where we are not looking at ERP responses. We did using Fisher's linear discriminant analysis. I will not go into percentages, because I know that this may be overfitting or underfitting, but I want you to appreciate the modalities that can be used and the pipelines that can be used to understand various diseases. So we had around 70% accuracy looking at EEG microstates in patients with epilepsy. Another disease is spinocerebellar ataxia. They inherit the they get it from their family, and it affects their movement, as Dr. Senthil was telling. Ultimately, a person who is able to walk and talk can survive, and that is what all of us are looking at. So when it affects your movement, when they are not able to move, that's a basic thing what human being can do freely. It is a very distressing condition. So what we wanted to look at was, there is no cure for this disease. And we want to look at what is the network correlate of this disease, so that we could look at which are the networks which are failing faster. So what we used is, again, we used resting state functional MRI, but we added graph theory measures where you can look at networks into this pipeline. So the processing up to the getting the matrix was the same. But graph, we looked at graph measures like global efficiency, clustering coefficient, small worldness, path length, and all these features. Then run into various pipelines, because we don't know which one will do well. So we did AdaBoost, and AdaBoost had somewhere around 94% accuracy, XGBoost with 98% accuracy, and the support vector with 92. Overall, all classifiers were doing the same thing. So it says that the networks in spinocerebellar ataxia can be detected, because network is not something that we see by doing an MRI. Network is something which we derive from the bold by deriving the matrix out of it and looking at the mathematical connections. So we were again very motivated after seeing this. Then we looked at gliomas. Now you know that the diagnosing glioma is saying that there's a tumor in the brain is easy. We can say that, okay, fine, there's a tumor in the brain. But what is required now is whether we can predict what genetic mutation is associated with that glioma. This is very difficult for us to say based on radiology features as to imaging features as to what genetic mutation could be there. So what we did was we did little radiomics, and we used bread and butter. T2 weighted is our bread and butter sequence, and then we looked at 55 patients with H3K27 wild type and 67 patients who were mutant in midline gliomas. That means gliomas which are there in the brainstem. very usually affects small children, and very difficult disease to treat. But if you have a mutation, that means you are benefited, you live longer, the disease is little better. So this is a pipeline that we did. We used radiomics, and intensity and histogram based features were taken in as features for this classification, random forest. No, I think it is XG boost that we did. And then we had an accuracy of around 90%, which is better than the eyes of a radiologist. No, we can't say that this could be an H3K27 mutant or wild. Even if we say using some features, it could be accuracy could be 70 to 80%. So this histogram radiomics has better than us in classifying. So there's another disease called essential tremor, which is again a neurodegenerative disorder like PD. It's where we used XG boost and got a 92% accuracy. Now coming to dementia, dementia is again a disease which is very disabling because it declines the memory. Just imagine what will happen to you if you lose your memory. You lose memory of who your father is, what your what happened yesterday, what you ate in the morning. It's a very disabling condition. So, and we do not know the etiology of what causes dementia. There's enormous research which is there, especially in pharmacy, to find drugs which could delay or stop the memory decline because it affects the prime age. So, imaging biomarkers, if we have a role in assessing the treatment response, is what we are looking at. So we had 3 groups of patients with dementia: Alzheimer's dementia, which is a prototype of dementias; the frontotemporal dementia, which is the second most common type of dementia; and patients with mild cognitive impairment. And we used a naive-based classifier using combination of 2 modalities. All this while I was telling about one imaging modality. Now we have used combination of 2 modalities, cortical thickness and FDG PET. So what we have done here is that we have extracted the features using pre-processing, we have parcellated it, and we have combined the PET and the CTH into one matrix. So what we have done is that we have weighted this PET and then we have derived the CTH, and then we use that in the classifier, and then the classifier accuracy was somewhere around 80%. The best classification between MCI and PPA, which are PPA is the mildest form of the disease. So, so that is, but this is, we could not get any features to correlate with the scores, but it is feasible that we can fuse techniques, fuse modalities, and derive data out of it. Autism spectrum, again we use XG boost, 81% in a DTI. DTI is diffusion tensor imaging, where we look at white matter integrate, white matter structure. All these other, what I told you regarding resting state is cortical blood flow. This is regarding the white matter that we have looked at, and we found that there was somewhere around 81% accuracy. But most interesting was that we could derive which was that feature, because once you give a rank to a feature, we can find out how related it is, how correlated that is with this clinical outputs. So we found that the connection between the anterior limb of internal capsule on the left and the interhemispheric connection to the right superior corona radiata was significantly contributed to the classification of models. This is very, very important because it is the interhemispheric connectivity which is abnormal in autistic spectrum disorders, is what is well known. So this is when we see something, when the machine tells us something which we already know, we feel happy. We're like, okay, fine, this fellow is thinking like us. So this was that. And then we looked at radiomics and looking at peritumoral radiomics, texture and tumor heterogeneity, shape of the tumor, and looking at implementing that into pediatric posterior fossa gliomas. You can see 3 tumors. This is ependymoma, round and white; medulloblastoma, round and white; pilocytic astrocytoma, round and white. All 3 are different tumors. Medulloblastoma has a worse prognosis if a child has medulloblastoma. Unless you resect it completely, that child will die within 6 to 7 months. But a pilocytic astrocytoma, even if you leave little bit, it's okay. So, but imaging wise, no, though we can make a fairly good diagnosis, I mean discrimination between them, we are not as good as the computer. We had 87 patients, medullo 32, pylo 25, 30 ependymoma, used a random forest classifier, using bread and butter T2 weighted image, single modality, had an 85% overall accuracy in discriminating between these 3 types of gliomas. Again, these are radiomics that we have used. Another one called the Duchenne's muscular dystrophy, where this is again an inherited disorder. It affects the muscles. And children are not able to walk. They're hypotonic. They're not able to walk because the muscles are very flabby. So, and hypertrophy. In DMD, you have hypertrophy of the muscles, but weak muscles. So, when we looked at the polymorphism, genetic polymorphism in DTI and finding out the network measures of the DTI, as input features, we found that there was around, with around 90% accuracy, we could differentiate those with 140 dystrophin isoform mutation compared to those without. So we can, from the brain, we can say, what type of muscular dystrophy, what type of genetic variation this patient could have, which is not possible with our conventional MR reporting. So now we became confident, so we started looking at deep learning approaches, PD and atypical Parkinson's diseases. It is easy to compare to find out difference between PD and healthy control, but a disease-matched control becomes very difficult, and that is what we do on a daily basis. No, we don't find out what is the difference between a patient and a control. We find out diagnosis based on different types of diseases. So this is real life where we had to differentiate between PD and atypical Parkinsonian disorders. We used convolutional neural network with inputs as contrast ratios, machine learning, radiomics, machine learning, and neuromelanin sensitive MRI as three different modalities we put in. And then we found that between the PD and APS, the neuromelanin sensitive MRI had the CNN had a higher sensitivity using the neuromelanin as intake in differentiating between the PD and the APD. We used T1 weighted neuromelanin random forest classifier, 77% accuracy, and only T1 without neuromelanin had 92% accuracy in with RF classifier. So patient versus control is relatively easier, but patient versus patient is relatively difficult, and that is what we do. And coming to tumors, look at these. You have 3 types of tumors. One is a supratentorial ependymoma, ring enhancing necrotic, high grade glioma grade 4 ring enhancing necrotic, high grade glioma grade 3 ring enhancing. All of them look similar. This is a T1 weighted image, the FLAIR image, T2 weighted ADC, and this is the segmented map. They look similar on conventional MR. It becomes very difficult to tell what is what. So then we used all 5 modalities, that is 4 actually, T1, FLAIR, T2 and ADC into the pipeline. We did the radiomics of all 3, and then we used 3 classifiers, support vector, random forest and ANN, and had an accuracy of around 80%. Overall, accuracy of around 80% using cross validation, which is fairly good. Which is fairly good that they'll be able to differentiate similar looking radiology, similar looking image wise, similar looking tumors. All are high grade tumors, but could differentiate ependymoma from high grade glioma, which is very good. So now using 80%, the ANN had the highest classification accuracy. Now coming to the bread and butter problem, we have tuberculosis in our country, which looks exactly the same as high grade gliomas, but the one high grade glioma, the treatment is deathbed. Tuberculoma, the treatment is ATT medicines. So this makes a lot of difference. Most of the time we are able to diagnose it in our brain using real intelligence, but sometimes we fail. and then it is catastrophic for the patient, because a patient who requires just medicine has to undergo an unnecessary biopsy. So now we use this explainability SHAP pipeline to look at what is a feature which could actually help us differentiate between them. We had 185 subjects, 51 tuberculoma, 50 metastasis, and 84 high-grade glioma patients. And then again use radiomics, and then looked at several different classifiers, and we found that AdaBoost and DextraTree classifier had the highest accuracy. What is significant is that we could find out that these are the features. I'm sorry, this slide is a little busy. The features which were actually driving the classification. The wavelet transformation was the feature which was driving the classification, differentiating between high-grade glioma and tuberculosis, high-grade glioma and metastasis. So I wish AI will help us see beyond the boundaries of clinical radiology, probably in some time. But we have to face some problems. In imaging, we have a problem of plenty. We have various sequences, various acquisition methods, and lack of replicability. What I do is not what my colleague will do. We have image analysis problems with ICA components which are not fixed, and then we have group results. And we ourselves do not know the biological correlate of what we actually find sometimes in the MR. AI platform, the problems are, it is a black box. So is our brain. Our brain is also a black box. You can't understand what is processing. I'm processing in my brain when I'm talking. So I have no problem it being a black box. But the problem is that trial and error, several methods. Each time I learn a new technique, new pipeline, a new method comes. And then I have to try that to find out maybe they'll better. More layers are not equal to better results. Sometimes SVM just performs the best. Pipelines are closed systems and not replicable, and then people do not share pipelines. But the most important factor, I think the director of IIT Mumbai was telling that we should get clean data, but the data is dirty. Variability and dynamics of human behavior is what is the norm. You can't get static, everyone to behave same for AI to work. It will not happen. So I think people should have pipelines which will deal with variability and dynamics of human behavior if you have to understand brain. Thank you.
Long live India and France friendship.